Hello, everybody, and welcome to this Aspire podcast on frozen embryo transfer, which is a very important topic for all of those who practice reproductive medicine. I'm Dominic de Ziegler. I work as scientific director at the Hospital of Cambodia in Phnom Penh, and it is my great honor and a fantastic pleasure to welcome and present Dr. Sian, who is sitting next to me and who is actually going to talk and present this podcast. Dr. Sian, you trained in Paris and in Singapore, and now you are the head doctor at the first ART clinic that opened in Phnom Penh 12 years ago already. Your entire team is dedicated to provide optimal, personalized treatment for infertile patients. In this context, you have dedicated remarkable efforts for diversifying the clinical options that are proposed to our patients, and notably for developing new options for priming frozen embryo transfers, which is the topic of today. As we all know, the number of frozen embryo transfers has exploded in the last decade for the reason that Dr. Sian is going to remind us. Dr. Sian, please tell us the challenges that are encountered when we are planning frozen embryo transfers in modern day ART and how important it has become in the recent years.
Thank you, Professor, for your kind introductions. It is my pleasure and honor that Aspire invited me to speak on this podcast. Yes, in recent years, there has been a significant increase in number of frozen embryo transfer. This is mainly due to three reasons. First, the use of antagonist protocol with ovulation triggering using the gabapentin has greatly reduced the risk of ovarian hyperstimulation, which used to be one of the most serious complications of AOT. And with this kind of protocol, we usually do frozen embryo transfer. So second, cryopreservation through embryo vitrification now provide the possibility to freeze and defer transfers without fearing any embryo loss. Third, the introduction of PGTA make it possible to avoid transferring embryo that have chromosomal abnormality, and that chromosomal abnormality cannot result in the live birth. This helps prevent unnecessary embryo transfer and emotional stress. In all these situations, frozen embryo transfer is required. And since FET is more common now, doctors are looking at the best way to plan and personalize its cycle.
Well, Dr. Sian, thank you for this introduction. Indeed, we do a lot of frozen embryo transfer. And so we are interested in all ART programs that have a need for frozen embryo transfer. And thank you for reminding us for the reasons that have led to this increase. In this context, please tell us which are the options that exist for preparing women for these frozen embryo transfers, and tell us the challenges that each of these options carry for our patients. Notably, tell us about the very original protocol that you and your team have developed at FCC in Cambodia for frozen embryo transfer in a context that is very original. The most interesting, because most interesting part of your option is that it respects the production of endogenous progesterone, which is an option that you have called the modified natural cycle. It is intriguing, and I'm sure that all the listeners to this podcast are interested and eager to learn about it. And so please tell us more about what you have developed in Phnom Penh.
Yeah, historically, most FET was planned using exogenous hormone to prime the endometrium. This approach is known as program cycle, and it was originally developed years ago for donor egg recipients who do not produce their own ovarian hormones. So as now FET become much more common, we started to asking important questions like whether there may be other approaches to do it. So a prospective randomized trial conducted by Kate Devines and colleagues in the US showed that vaginal progesterone alone was not sufficient to properly prepare endometrium in program cycle. Subsequently, there is several studies, particularly from Elena Labata team in Spain, demonstrated that vaginal progesterone is used. Serum progesterone level must be above 10 or even 20 nanogram per ml to minimize the risk of implantation failure and early embryo arrest. Because of this, many women had to use injectable progesterone, which can be difficult for many women undergoing frozen embryo transfer. So therefore, we think of other approaches that may be simpler, more physiological, and safer for patients.
Dr. Sian, thank you for reminding us. The work by Kate Devine has been a real bomb. It has indicated that vaginal progesterone by itself is not sufficient, and therefore it has led people to use injectable progesterone, which is painful. And this has led people to choose different options, and therefore we are very interested in knowing what you have developed at FCC in Phnom Penh, Cambodia, which is intriguing, which is interesting because it applies to possibly most women. It avoids injections. And you've called this the modifying natural cycle. Can you tell us more about it, please?
Thank you, Professor. The natural cycle option can be problematic in women who do not ovulate regularly. So we designed an original modified natural cycle with two main objectives. First, we wanted to take advantages of endogenous progesterone production from couples which avoid progesterone injection. Second, we want better predict follicular development and ovulation, which make monitoring easier. So to evaluate this approach, we compare outcomes between women undergoing program cycle and those undergoing modified natural cycle.
Very interesting. Indeed, the new issues that have been raised, notably regarding the levels of progesterone, notably regarding the need for injections, has generated a lot of interest for protocols that what you have developed. Can you please give us more details in what you have done and how it is conducted and how you have compared that to other options?
Thank you. In program cycle group, women receive estradiol 8 milligram per day for about 10 days. Once the endometrium was about 7 mm and serum progesterone was confirmed to be low, vaginal progesterone was started along with injectable progesterone every other day. And blastocyst transfer was performed on the 6th day of progesterone. And hormonal support continued for up to 10 weeks. In contrast, women who prepare in modified natural cycle receive letrozole 5 milligram daily from cycle day 3 to day 7. And ultrasound monitoring began on day 11 of the cycle to assess follicle growth and endometrial thickness when the dominant follicle reached at least 17 millimeter and the endometrium was above 7 millimeter, hormone level was checked. I would like to inform that patient need to come for several times to monitor the early surge and its subsequent drop. And then vaginal progesterone was then started and blastocyst transfer will be performed on the 6th day of gestational also.
This modified natural cycle is really interesting, and the way you've developed it is really smart, because one of the problems that many people encounter when they want to do transfers in natural cycle is that women are unpredictable, and women will not ovulate regularly, and therefore, particularly in the context of stress, you may end up with problems and wasting time. So your intervention, which consisted in adding letrozole for assuring that follicle develop, is really, really smart. I'm stoned by the fact that you did this, and I have a lot of admiration for that. Now, the question, of course, is what are the results? What have you found? Please tell us more.
Yes, our finding confirmed that this modified natural cycle is highly effective. We analyzed several hundred frozen embryo transfer across both protocols in both PGTA tested and untested embryos. As expected, implantation rates were higher in PGTA cycle overall. However, within each group, outcomes were very similar between program cycle and modified natural cycle. In other words, how we prepare the endometrium doesn't change the success rate, so we can adjust FET preparation to fit each patient needs and preferences.
Thank you, Dr. Xian. This is very interesting, because actually it is true that women don't like injectable progesterone, that it is difficult for the service, but women have to come for the injections. And therefore, by developing this new option, we are extremely grateful for what you have done, and we found that this is very smart. Your data have been shown in a very elegant way, and therefore allows to tailor personalized medicine for our patients. And I wish to congratulate Dr. Xian for this, because I think this is truly beautiful. And I think that all the listeners of Aspire will be inspired by this presentation. Thank you.